Hi, my name is CJ Devgan, and welcome to Season 2 of Breaking Barriers. My goal for Season 2 is to discuss how digital transformation is redefining how care will be provided in the next 5, 10, and 20 years. I will be talking to leading minds in the healthcare sector and exploring how new disruptors are leveraging technologies such as artificial intelligence, population health, blockchain are reshaping the healthcare universe.
Hello and welcome back to another episode of Breaking Barriers. My guest today is Todd MacCallum. Todd is joining us by phone from Ottawa. Welcome, Todd. How are you doing?
I'm very good. Thanks for having me today.
Thanks for joining us. So before we start and get into the thick of things, may I ask you to share a brief professional experience with the healthcare systems and also a fun fact about yourself with our audience?
For sure. So I've been in healthcare for a little over 25 years, mostly on the technology side and coming more from the vendor and technology side of the house. So began the traditional IT and around 15 years ago got more involved in the clinical IT side of things. I guess what drew me to focusing more on healthcare and clinical IT is I like being a part of solving complex problems. And I haven't found a sector of the industry anywhere yet as far as IT goes where the challenges could be that complex. So it keeps me mentally engaged. So I've also spent a lot of my time volunteering from the HIMSS side of things, so the Healthcare Information Management System Society, which is the largest healthcare information management society in the world. They're the ones that develop things like the MRAM maturity model. And I've been involved with them across North America, but mostly across Ontario, leading the local chapter in various capacities. Just kind of bringing in some, local discussions and kicking around how we're going to attempt to skin the cat of healthcare and move the needle forward while the ground shifts under our feet every 4 years as far as the ministry goes. So that's sort of where I've been spending my time. And these days, more and more on an airplane across North America and internationally as well, getting involved in developing some more clinical use cases for IT and new innovations and attempting to bring industry standard technologies into the traditional kind of monolithic proprietary world of healthcare and working through some models to drive new healthcare outcomes with artificial intelligence and machine learning and these types of things, but working closely with clinicians in that regard, as opposed to developing solutions in isolation of what the actual needs might be. And a lot of that's focused around the healthcare system side of things. So that said, I'll stop there. I could talk forever about this stuff. And interesting fact about me, I'm not sure what's that interesting. I've been born and raised Ottawa, and I enjoy playing hockey as a goaltender and being a drummer in a band when I used to have time. And as far as I've seen in Canada, that's very common to see a goalie drummer duo role for a lot of people. So that's my interesting tip about me.
Wonderful. Yeah, neither of those two things I have ever done. I used to live in Ottawa. I tried to do skating, fell on my as if I say so multiple times. And that was the extent of it, But I would love to, go out on the rink, especially during the Winterfest and enjoy the cold. So let's get back to the healthcare side. As we discussed before, our focus for this season is on the latest trends that are driving transformation in the healthcare sector. And as you mentioned, your association with HIMSS, which has been at the forefront of establishing various standards. And just last week, we had an episode talking about the truckload of data that is going to be created, if it is not already being created, from all kind of things that we are wearing on our body, and Internet of Things, wearable devices, appliances inside our homes, capturing our data and collecting all that data into some kind of cloud infrastructure. And one of the challenges we talked about was interoperability of data. I just want to get your experience based on your association with HIMSS and various Ontario chapters. Where do you see the future of that, and how do you see we able to actually get a seamless flow of data between all these vendors in near future?
When you say a seamless flow of data from all these vendors, unfortunately, I never see a day where that happens, but maybe it will happen. I think when it comes to interoperability, I've been involved in that from various different angles, from the HIS vendor angle, from the DICOM vendor, diagnostic imaging angle. You've got a number of factors there. So obviously I think we've made a lot of good strides in terms of interoperability and what we're able to do, at least at a certain level. We sometimes can't get as far and as deep as we'd like to get as far as integration goes, but it's a lot better than it used to be. But a bigger challenge there is really just data standards and nomenclature. So the fact that if you can bring together 5 or 8 different systems, say, hey, we're going to pull all these data sources and come up with one, patient record from all these different vendor solutions. You'll have sometimes just, different healthcare terminology and whatnot. Organizations like SNOMED have attempted to, overcome that from various, viewpoints. But that really doesn't address, the complete patient and all data sets you can have in there as well. So I like to come at it. I think we need to kind of do both. I think we need to look at things systemically and deal with overall data standards and do our best to, encourage or force our vendors to comply to a certain extent. But I think we need to tackle the problem at a tactical level too, because when we just say we're just going to have some common pool where all data comes in and anyone can do whatever they want with that data, I think that's just too large and too loose. So you can look at, let's just look at tackling cardiology for a patient population, for example, and build it out that way. I find you can achieve an outcome that way, and you can kind of do that point by point, but still with an eye on the overall vision. And as long as you have those standards to kind of wrap it, you can get to the point where you can build towards that, if you know what I mean. I've seen some vendors or some organizations, mind you, sorry, not vendors, providers, attempt to address this with a single vendor solution like Epic or something along those lines. You only go so far. It's a very foundational, fundamental move for an organization, and it does, in my opinion, reduce a certain measure of complexity, but you'll never get across the entire organization and eliminate all applications and all various data sources and have to the part where you have no integration at all. So that always will be an element you need to take into account. So I could talk about that one forever. I think, again, there's been lots of progress made, and I think we are getting there. And I think whenever we're doing anything now, we need to think very carefully, long and hard, if we're doing something that isn't industry standard and doesn't comply. And unless you have an extremely compelling reason to move ahead with that particular solution or whatever you're looking at, I think we need to stop implementing these types of solutions going forward.
I completely agree with you that we have made a lot of progresses, but there's still a lot of distance we still need to travel. So with that said, and given your 25 plus years of experience tackling difficult challenges within healthcare space, what do you see as the biggest obstacles in adoption of technology where Canadian providers, because right now even our providers are working in silos. My PCP is not communicating with the hospitals that are supporting our hospitals, are not communicating with our PCPs and so on. So how can we at least get these key entities communicating with each other more real time? So what from technology, because technology exists today, right? There are organizations, entities that are using it. Kaiser, for example, they have made a lot of strides in the US in terms of seamless flow of data and communications between their care continuum. Why are we struggling so much? So what is your opinion on that?
Well, what I'm going to do is I'm going to regurgitate some opinions I heard a couple of weeks ago. We were having a small HIMSS conference, and I was on a panel with various CIOs, more listening and asking them questions. They were the ones doing the talking. And the context there was around Ontario Health Teams. And this applies to really any organization, in my opinion, globally. Health Teams is a specific model. Yes, it is. But it's really more around continuity of care and partnering with other organizations in order to deliver that care, and digital being really a key foundational element within being able to deliver that. And what came out of there, technology is really not the major obstacle in the way. The major obstacles are more around policy and funding and governance. And so to give you a specific example, I know of a couple of hospitals in a healthcare jurisdiction in Canada that deal specifically with pediatrics, and they share a common platform. Actually, both systems are in a shared data center, and they have no problem sharing data between their systems because they're actually the same technology platform, but they are not allowed to share the data because of privacy. And so these are elements that get in the way, and unfortunately, they take a long time to move these needles. But I think we need to bring in, legal and the executives and policymakers to, help point to them to where these problems exist, to have them adapt policy. Another thing you see now is you hear things like axe the fax. Why are we even talking about fax machines still? That's because of policy. That's nothing to do with technology. There's a lot. We could easily be setting this stuff, through secure means, not including fax at all. And I've seen scenarios where they get around and they deal with it digitally by using, digital faxes and sending around PDFs, which is really a silly workaround. So, I really think it's not technology. Technology can get very complex. I'm oversimplifying it, but I think it's important to really drive home that point that it's really not technology that's the key bottleneck that's in the way in Canada.
So very valid point about regulations, policies, and I have tried to reach out to some policy people to join our podcast. I have not heard back from them yet, but that's one of the constant message that we are hearing on these conversations, that it's not the technology that is the biggest obstacle. It is the policies that we have, which are built in 20th century and not built for 21st century. Like you said, why are we still talking about fax? Who uses fax these days? So from technology, I know we want you to talk about more technology use cases and how they are improving the care that we offer to our patients. And you shared with me a white paper on this thing. So let's go into that. Talk to me about this SurgeCon solution that you shared with me.
Yeah, for sure. It's an example, I think, of a point solution that can deliver value, and it takes on that open industry standards approach. So this is a solution basically built with some emergency department doctors that had come up with the KPIs, and they've identified what were the key factors that would affect the volumes that were happening within an emergency department, and then overlaying that with protocol. So when certain scenarios are happening, what do you do next? And that's why they called it SurgeCon. Essentially, it's around the idea of the DEFCON 4, DEFCON 5 idea. So it's the surge element of that as it affects the emergency department. And then they were applying this methodology from a practical standpoint, and we work with them simply to digitize it. So in this case, it was built on industry standard platform and Red Hat and your standard DevOps is happening in any other industry, and a built-in integration engine, and then the ability to be able to have built-in machine learning and AI and whatnot. But yeah, so taking that philosophy around new technologies you might be looking to implement and using that approach, but then interfacing that with existing emergency department information systems, interfacing that with EMS systems from ambulances that are in the field and whatnot, and then interfacing that with back-end bedboard systems. Because you're rarely going to get a forklift scenario where you can replace all systems. You need to be able to vector across those departments and stakeholders to build out an end-to-end continuum solution. You need to leverage those things, but using new tools rather than reinventing the old or standing up another silo that fits in the middle of all the other silos. So in this case, what they were able to achieve is a solution where it automatically aligns clinicians to demand in real time within the emergency department. So it's automating, the communication, the workflows when certain elements happen, when people are coming in and registering to the emergency department. that's triggering events and instructing certain people within the hospital, what to do next, warning or notifying inpatient departments of, what's happening and whatnot. And then also on the ambulatory side of things, and informing the receiving emergency departments, what patients are coming, the acuity of the patients and whatnot. So really and then you take all that data, and then once you have that, and you've been, like any data, any analytics you want to run, the more data you have, the more you can leverage that for being predictive, right? So then you can not just look at trends and say, okay, this happened, so now we can do this next. It can actually start to predict what's going to happen next, and that can get to the point where it's not only informing people involved in the flow and preparing them across the organization, but also doing things like proactively updating scheduling and bringing in more staff if needed, because you'll often have a situation where, especially in Ontario, where, the hallway medicine's, the big buzzword being used, everyone's working overtime all the time. They're paying a ton of overtime to the staff and burning out the staff because it's a very difficult environment to be able to know what's going to happen next. So the automating of it, and then also getting predictive as well, is gets to the point where you're getting more capacity out of your existing infrastructure and people, better quality of care. When people come in an emergency department, it's a faster door to dock time is a key metric that's used in that regard as well. So a huge patient safety issue avoided by having patients moved in and out or potentially into beds quicker. That's one example of a point solution that was built, but with those interfaces in mind, but in a industry standard approach, and then allowing you to use AI and analytics and whatnot.
So help us understand, if I was the hospital, if I have to implement something like this, what additional infrastructure would I be looking to install? So as a patient walks into an ER room, they go and meet a triage nurse, they take your vital signs, ask some basic questions. So that is whatever existing software they have. So this piece of software will sit underneath that. So once that data is collected, it then starts to do some predictive analysis on the severity of this patient. How does that function? Help me understand that a little more.
Yeah, so it's essentially, I'd say it's invisible and works across systems, right? So it's important that you got to be really careful when you get a clinician or administrator to change the way they do things. So it's really critical to do that. You want to work within that. So they receive their patients, they admit their patients the same way they would have always done it. And then those data feeds would go into the platform that we have in this case, SurgeCon, and then it would make decisions based on the existing hospital's protocols, or we can help them adopt, industry standard protocols around the clinical side of things, which is a different conversation. But in a lot of cases, hospitals know what they want to do. They just can't execute on it as effectively as they feel they should, because everything's always manual. You have people sitting there, best case scenario, watching dashboards, picking up the phone, making phone calls. So in this case, it would put the information up on a dashboard that would be viewable in the emergency department and receiving wards if necessary, inpatient units. But it would also, everyone's using cell phones anyway, so it send automated messages. It's secure. There's no patient data being transferred. It's just giving instructions to that individual on what to do next. If there's a paramedic that's in the hospital and they need to come back to the emergency department, it notifies the paramedic, come back to emerge and report in, does that automatically. And then if any receiving units need to receive any other information, it will automatically inform them as well. So it's not a different application, but it has, like I said, that visual tool around the dashboard, and then using automated SMS messaging to instruct people what to do next.
Okay. The area that I'm still struggling to understand completely is, how does it increase the throughput of that ER department? Because the number of patients that they're going to see doesn't change, and the time that a physician is going to spend on those patients is not going to change. It's just the prioritizations of those patients may change, correct?
Yeah, so what it's really doing when it comes to high volume emergency departments, it comes down to saving minutes, seconds and minutes, right? And so when you're doing that, when you're able to stay on top of it instantly and communicate instantly what's to happen next, or when you need to inform 8 people when you've moved from a certain surge level to another surge level and there's a new protocol that needs to be implemented, everyone's informed on what to do next instantly. So it's really more a matter of that and automating those protocols and those instructions that adds up to, weeks, not maybe just weeks, but, days per month could be saved, which is a huge time saver from a avoided or cost saver from an avoided overtime perspective.
No, I completely agree. The whole idea for delving into a case study is so people who are listening to us, especially if they are hospital administrators or technology leaders, then they can take that product, look at their landscape and see how best they can leverage that technology and improve their processes. So this is great. So you mentioned who would they need to contact if they think of this technology as a viable option for them? Do you have any contact detail, or they can just contact you to get this thing?
If they wanted to find out more, they can contact me. I'm the healthcare lead for Mobia, so I can do that. And I don't know if we have time. I've got actually a better example. If you want to talk about interoperability, I have a better example.
Yeah, please. Absolutely. We are hitting at the bottom of the hour. We may be able to go 5-6 minutes more.
Sure.
Yeah.
That's an example of what you can do across existing systems now. This is not, again, I don't think this is really rocket science, but it's an example of working across existing systems. So there was another project that my company had worked on. The product that ended up being developed was called MyCCAT. It's around automating e-referral for cardiac cath lab. And what that made a little bit unique is the fact that it was acuity based, right? Because in cardiology, it can't be first in, first out, or people die. You need to pull them in and schedule them based on the acuity of that patient. But in this case, at a very simplistic level, what was developed is a single workflow and a single pane of glass for that workflow across the province, but across systems, right? So you've got a referring physician or specialist in their office in Carbonear, Newfoundland, and they're in their TELUS EMR, and they're with that patient, and they decide this person needs to go in and go get an appointment into the cath lab and refer them in. While they're in the TELUS EMR, they go into their provincial portal, launch the cardiology e-referral that grabs the MRN number from the TELUS EMR, does a lookup to the provincial patient registry, auto-populates the demographics for the referral form, pulls that data into our platform, and then sends that into central scheduling, updates, in this case, Meditech on the back end. And then we're able to also interface with that with CVIS and those cardiology information systems to be able to pull in even the post-op information on, from when you scheduled that patient, when you assessed them, to what was the impact on the operating room table to that patient. And you can look at that whole value-based flow. The reason I mention that is because that's across all sorts of traditionally proprietary systems, but that is what's possible now with, where we're at now with standards. It doesn't solve the whole problem, but in the case of cardiology for the cath lab, we were able to integrate pretty much all the data right across the care continuum using open source tools that are available out there now. So that's just one example of where you can get to with today's technology and open tools.
And so right now, when we're talking about this integration, so data was flowing across the organization's boundary through internet, or how was the data flowing through? Or it was all inside the hospital's firewall?
Well, this is across organizations, but this was on the hospital's. Actually, it was not even their closed proprietary. It wasn't any closed network or anything else. It was all secure and encrypted. It would have been, within and across their various systems, they're already secured, like the patient registry and whatnot. I can't get into that level too much. I mean, my expertise was not on the security and privacy side of things when it comes to how that was implemented.
Well, that's fair enough. I just want to make sure that audience understands that the data was leaving the four walls into a cyberspace cloud, and then from that cloud into the second provider's facility.
Yeah, this complied. I mean, this went through a provincial privacy impact assessment and passed all of that. So this was all in compliance with existing provincial privacy standards.
Okay. Perfect. Fantastic. We are almost there, a couple of minutes over our allocated time for this podcast. I want to thank you for your time, Todd, and sharing your experiences and giving our audience more insight into the SearchCon tools and other things that your company do. Do you want to take a couple of minutes and talk about anything and share your contact information with anyone who may wants to contact you?
Sure. It's I can share my email. It's one of those long Scottish names, so it'll take me a second to spell it out. So it's Todd MacCallum at mobia.io. IO standing for innovations. So it's TODD.MACCALLUM as in Michael at mobia.io. So if anyone wants any other information on any of these things or wants to get involved with HIMSS at all in Canada, send me a note. Happy to talk.
Thank you again. Have a wonderful weekend, Todd, and I look forward to staying in touch with you.
Great. Thank you very much.
Take care.
That is all for today. Thank you for listening. If you are a healthcare executive and grappling with challenges to transform your organization, contact me and let's talk. If you like our show, please subscribe, leave a rating and a review for us on iTunes. Ciao and have a productive week.